So we are live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research and Education Foundation. To introduce today's topic and the speaker, I hand over to the chairman of Oref, Dr. John Mukhopadhyay.
Thank you, Neeraj. Welcome everybody to today's program. Today we have Dr. Gautam Prasad, our spine surgeon, who's going to talk to us about lumbar canal stenosis. I think this is an important topic and could well be an examination case as a long case for the DNB and MS students. I think this is an area where there's sometimes a lot of confusion, both in the clinical examination and presentation. So I will hand it over to Dr. Gautam to clarify these doubts and give his talk on lumbar canal stenosis. Over to you, Gautam.
Thank you very much, Dr. Johnson. Good evening, everyone. So I'm going to talk on lumbar canal stenosis, and lumbar canal stenosis basically it's a when we talk about lumbar canal stenosis, we talk about the passage and the passenger phenomena which is actually happening. And lumbar canal stenosis is something which is something for a spine surgeon, it's a bread and butter thing. So we always come across patients, or most of the patients are for degenerative spine, and as if it's more important in clinic, so it's more important in examination also. What I'm trying to cover in this topic is we'll go through the etiology, how is the clinical presentation, the differentials, the diagnosis of this, how to evaluate the patient, and the management options. So let's look at this slide. So if we see at the figure 1, 2, and 3, in one, it's a spinal segment which has been shown. So a spinal segment is typically two vertebrae with a disc in between the facet joints of both the vertebrae and the roots, the chorda which is in between. So as the degeneration occurs, we go to the next stage, that is stage 2, in which there is decrease in height of the disc. There is some early osteophytes being developed. The facet, they show early arthritic changes, because of which the canal decreases, and so decreases the root canal. In the next stage, there is increase in osteophyte formations, and with this, if you will notice on the third image, the superior articular process of the lower vertebra, that also goes on impinging the root from behind. The facet joints, they impinge the root from posteriorly, and the disc osteophyte complex, they impinge the roots from front. So that's how the canal gets compromised, the neural canal gets compromised. And when the neural canal is being compromised, it's not only the foramen which is being compromised, the central canal which is being compromised. So as it progresses, the etiology is degenerative changes of the disc, progressive arthropathy of the facet joints, collapse of the neural canal, and encroachment of the neural foramen by the disc from front and facet from behind. Many times, patients, they have inbuilt primary neural canal stenosis. By that I mean that to begin with, the canal is not very wide enough. So these patients, they have canal compromise right from the beginning, and slightest of compression will increase the symptoms like anything. So basically, when we talk about lumbar canal stenosis, it's always a passenger compromise which you are talking about. Let's have a look on this MRI picture. So it's a T2 weighted image that we see. On the left, we see a normal spine in which the disc, the spinal segment, and the nerve roots, the posterior elements are very well seen. The white thing that you see is the CSF, that is a chorda that we see. And the axial picture also shows very well the axial cut. The roots are very well seen over there on exiting on either sides. Now, when the degeneration happens, the disc from the front or the facetal arthropathy from the backside, that keeps on encroaching this space, and on the axial, we will appreciate that the facets have overgrown. At times, between the facets, there is synovitis, which may in future also become a synovial cyst. So all those things, they compromise the canal, and that leads to symptoms of lumbar canal stenosis. Just like previously, as I mentioned, that there are some people who are born with stenosed canal. There are some people who are born with wider canal. And these guys, they have a slower progression of this symptoms, even if there is a good amount of canal compromise. They don't have that much of symptoms. The patients who have congenital stenosis, that means the canal is already narrowed, the interpedicular distance is less. These are the one who are more prone to have spinal stenosis symptoms. So basically, we can classify lumbar canal stenosis on the basis of the bony anatomy. So in that, we can classify into something like a congenital or an acquired. Congenital is one in which the primary stenosis previously existing, and in acquired, the disc, the facet, or some other pathology which affects the canal, that is the cause. Another way to classify lumbar canal stenosis will be either it can be a central stenosis in which the total canal is being compromised, or lateral recess stenosis in which the lateral exiting part of the path of the root that is being compromised. A typical canal stenosis will have facetal arthropathy from both the sides. There will be flavum hypertrophy or buckling of the flavums, and disc which is bulging out into the canal. There are some atypical or complex lumbar canal stenosis that we can classify, in which it is not the typical that we see, it's all atypical. So what it can be? It can be either a failed back, like a previously operated surgery in which the patient has developed scar, or there is a iatrogenic listhesis which has happened. So that constitutes as a failed back leading to lumbar canal stenosis. Second is degenerative listhesis. So in degenerative listhesis, the disc and the facet arthropathy has gone to an extent that the listhesis happens, and many times it is a mobile listhesis. So these are the degenerative listhesis causing stenosis. Scoliosis, degenerative scoliosis is another cause, especially if the curvature increases more than 30 degrees, then we need to even instrument these cases. So that we'll see eventually. A lumbar canal stenosis may coexist with a cervical stenosis, or there can be some pathological stenosis, like in situation like where there is an osteoporotic fracture, in which the fracture segment retropulse fragment that causes stenosis of the quada, or there is an infection like a tuberculosis in which there can be instability, there can be pus, there can be granulation tissue, which in combination of all one or more of these things can lead to canal stenosis. Similarly, a tumor can lead to stenotic symptoms. Now, what are these symptoms? The clinical symptoms most commonly that we see is the leg pain. The second most common is leg pain along with back pain. And back pain, isolated back pain, is not a very common phenomena that we come across in lumbar canal stenosis. Now, why there happens a back pain in lumbar canal stenosis? The reasons are degenerative processes. So the degeneration of the facets, disc degeneration, these both are known to cause back pain. Along with this, venous hypertension or neural ischemia can lead to increase in back pain. Many times, along with the degenerative or lax ligaments, there can be increase in mobility, which can be a dynamic stenosis. That is instability, that denotes instability. So this instability pain, especially while bending forwards or backwards, or extension catch which the patient develops, these can be the cause for back pain in lumbar canal stenosis. Now let's look at the reasons for leg pain in lumbar canal stenosis. So one is the mechanical compression. So the mechanical compression is then accompanied by venous blockade. If the venous outflow is reduced, then eventually the arterial inflow will decrease, and because of this, there will be inflammation. All this put together will lead to ischemic changes. To begin with, any ischemic changes will lead to some reversible changes in the nerves, and eventually this reversible becomes irreversible. That's the time the patient develops numbness or weakness in that particular nerve root. Whenever we take in history, we have to check out all the things. Like if there is a pain, whether the pain is unilateral or bilateral, then what is the onset? Usually, lumbar canal stenosis is typically present with a gradually onset chronic pain, but you have to inquire about that. Suppose there is sudden onset pain, rapid deterioration, then one might think that the lumbar canal stenosis is accompanied with extruded disc or a disc protrusion or some additional instability or infection. So how is the pain? How is the onset? How is the progress overall? That has to be noted. Another thing is claudication. So claudication is the distance that patient can travel, can walk without taking a break. So if we carefully ask the patient, then the patient will give in history where the claudication distance has been gradually been decreasing. Next, you try to find out whether the back pain is more severe or the leg pain is more severe. So on clinical ground, we want to be sure that whether patient has a leg more than back, because if leg is more symptoms, maybe a compressive surgery might be enough. But if back pain is more severe, then we might have to add a fixation in this patient. Also, many times LCS is fooled by other disease also. So to rule out that, always take in history whether the patient has any other symptoms in upper limbs, any bladder bowel involvement, any medical history like a diabetes or Parkinson's or any spinal surgeries in past, and also try to gauge what's the occupation of the patient is and how the patient has been before the onset of the symptoms. So for a patient who has been an athlete who is now able to walk 1 kilometer, but he has been an athlete for the earlier period of his life, so that 1 kilometer distance for him is actually a disability, because he was walking or running for 10 kilometers, 12 kilometers at a stretch, and now that 1 kilometer walk is actually a disability. Whereas for a person who has been living a sedentary lifestyle and he is walking 500 meters, but previously he was just walking 600, 700 meters, he did not walk more than that. So that 500 meters in this person might not be a disability. So we have to individualize what's the patient's expectation, what's the disability, and then take a call. Once we go through the history, we have gone through the history, then do the clinical examination. The stance of the patient, how does the patient stand, whether the patient is bent forward, and how is the gait. Usually the lumbar canal stenosis patient, they tend to bend forward because in flexion the canal space increases marginally and that increases the vascularity. So they tend to walk with crouch forward. But if the gait is abnormal, there is antalgic gait or there is broad based gait, there is unsteadiness, waddling, it denotes that there is something else, where there is a neurological involvement. Broad based gait can be in some in patients accompanying with tandem stenosis, that is cervical myelopathy along with lumbar canal stenosis. Antalgic gait might be because of a protruded disc. So all these things has to be taken into account. Whether the patient is able to walk on heels or not gives us a broad picture of any neurological deficit. Do regular full neurological examination. Check out the flexibility, whether the patient is able to bend forwards and backwards. Is there any extension catch while getting up, getting into extension? And how does the patient get into the bed? Also inquire whether the patient has got any other joint involvement like hip, knee, because most of times the degenerative process which is seen in spine is also accompanied by degenerative process in hip as well as knee, and many times one gets fooled. And if the hip is more pathological, then one has to give more attention or first priority to the hip and not to the spine. So we have to always look out for that, to detailed examination of hip, knee as well. And along with that, many times neurological claudication can be confused with vascular claudication. So always look for the distal pulses. Remember, the dorsalis pedis examination can means it can be absent in up to 30% of the patients. So tibialis pulsation should be felt, and reflexes should be seen in all the four limbs, so that we rule out any upper motor neuron signs. Once we have done that, then it's mentally we are prepared that we are dealing with lumbar canal stenosis, And the most important pathological, the distinguishing feature is the lumbar canal stenosis will be neurological claudication. So the distance goes on decreasing, and over a period of time, the claudication distance comes down. Also, check out the dermatomal distribution, whether the leg pain is constant on flat surface, slopes on stairs, is there any hypothesia involved, and can the patient walk claudication distance after each sitting or break. Many times we get some non-typical symptoms in lumbar canal stenosis, in which it might be some imbalance while walking, or there can be some rest pain, there can be numbness without pain, or radiculopathy without any true claudication, or there can be significant neurological deficit. Usually in patients who have been having this problem for a long time, the reversible changes become irreversible, and that time the smallest of thing can lead to neurological deficit. So these patients carry not so good prognosis, and that has to be evaluated beforehand and explained to the patient before we opt for any other surgical management. Specific issues in lumbar canal stenosis. So if the patient complains of pain in only localized to one side, one leg, or it's one leg more than the other, then we have to look out whether there is any culprit disc on that particular side, or whether there is accompanying scoliosis or increase in facetal arthropathy, or the facet joint over there has thrown out a cyst. The synovitis have developed, and that leads to a cyst formation. So that has to be looked in, because each and everything what we are going to see in that one side pain, why it is the reason we have to see, because if there is a facet cyst, it's a sign of instability. You need to fix it. If there is a disc protrusion, that needs an excision. So simply laminectomy or facetectomy is not going to help. So your decision making depends on how well you read your MRI, and for that you need to take a detailed history and do detailed examination. So if the patient comes down with severe back pain, it might be because of listhesis. Many times we do this X-rays only in lying position. So and there might be some dynamic instability or dynamic listhesis. So in such patients, we should always go in for lateral exercise in flexion and extensions, so that we don't miss on that instability part. And if possible, do standing X-rays, so that we even take into account the global alignment of the lumbar vertebrae. If there's a bladder bowel involvement, rule out that there was no previous history of urinary issues like BP in gents in male, and also rule out that sacroiliac joints, hip pathology, or other degenerative, non-degenerative reasons, infection, tumor, those are not the cause of this, because then accordingly the management will change. Many times this Parkinson's or other extrapyramidal syndromes, they coexist, and even at times they might be the leading cause for the patient's disability. So always, if you are in doubt, don't shy from taking help from a neurologist, and we need to rule out all this before we plan definite management for this patient. Vascular reasons that I've already told before. And there's something called as tandem stenosis. This is a vague term, but it's used for something in which there is coexisting cervical as well as lumbar stenosis. So in our experience, we have found almost up to 5 to 25% of the patients in lumbar canal with lumbar canal stenosis, they have a coexisting cervical stenosis. So always make it a point that whenever you do a MRI of your lumbar spine based on your clinical examination, you're suspecting only lumbar canal stenosis. So see to it that that MRI that you do includes at least one sagittal pic of the entire spine, so that you don't miss any cervical lesion or cervical stenosis. Imaging wise, the most important is the MRI. And in MRI, what we actually try to look is, how is the facet joint? Is there any synovitis? Like in this picture, the topmost picture, the white thing that you appreciate on both the sides is actually the facetal synovitis that we appreciate. The black thing in the canal, that is a flavum which is being hypertrophied. If you carefully look at in the central canal, there's something which is concave right in the upper side. So this is the disc which is being bulging. So this is a generalized bulge. This is not on any one side. So disc is not the main culprit. The canal is being compressed. So it's typically a case of lumbar canal stenosis. Now, lower down the left side that we see is actually a facet cyst. If you can, the arrow has been pointed out. So a facet cyst develops from a facetal synovitis, and there is cartilaginous degeneration, which is being shown in the another film. So all those things has to be taken into account. And facetal arthropathy can present with either one more than other side. There can be even instability. So that has to be taken into account. Now, many times, most of the orthopedic surgeons, they want to know from the MRI what is the canal diameter. Now, this canal diameter is typically taken at the bony level most of the time. So, and what we are interested is at the disc level. So, this diameter which is being there, which is being reported, is most times not accurate, and what might be 12 millimeter inadequate for somebody, it can be adequate for another person. So always look at the entire picture and don't go by just the measurement reported on the MRI films. So the absolute canal diameter with respect to the what the present condition is, that is more important, and that we have to correlate with the clinical symptoms. Apart from that, if there is any unrelated or unexplained neurological issues, don't hesitate to get EMG and NCV studies done. If there is vascular issues, check out for with Doppler studies. Hematological test is equally important. I still remember there was one pediatrician from Goa. He was due for surgery with us, and he had almost booked his dates for surgery. And in pre-op investigation, we found that his hemoglobin was 8 or less than 8. When we inquired, he was suffering from piles. So we asked him to just get his first piles treated, and you'll be surprised, after 2 months when we called him, he didn't turn up. So we called him. He said the piles has been taken care of. I have undergone a surgery, and the hemoglobin has shot up. It's more than 10, 11. It's around 10, 11. And now the vascular claudication the claudication that I was having has reduced significantly. So all these things that has to be taken into account. Anemia itself, that means the anemia was there, and this patient was having relative ischemia, and that was corrected by correcting the anemia part. As I mentioned before, imaging of hips and knees is equally important, and that has to be taken into account. Now, once you take into, you know the clinical history, you know the imaging, and you know that the patient is disabled, what are the treatment options? Now, role of conservative management. To begin with, it's always conservative management. But for whom it is conservative management? A patient who is not significantly disabled is a candidate for conservative management for LCS. But the patient who is disabled, the only management is surgical. It might be either a pain block, or it can be a minimal invasive surgery, or it can be a open surgery with or without fixation, whatever it is. So if the patient is significantly disabled, clinical radiological it's matching, then only treatment for disability is surgical intervention. Conservative management will be in the form of NSAIDs or brace, physiotherapy, which is the main thing, and lifestyle changes. Now, in surgical management, you always look for, before we you always discuss with the patient regarding the natural history of this disease. What you're trying to do is only at one level. The same thing can happen at other level or the same level again and again. What are the risk benefit ratio? You have to discuss in details everything, and always be aware that the only absolute indication is neurological deficit and rest pain. But in today's era, you don't wait for a patient to develop neurological deficit or irreversible damage, which in the form of rest pain. So the relative indication is there's a pain which is disabling, a pain which is causing loss of activities of routine daily living, or decrease in his ability to stand, walk, and perform his routine activities. So all those things are now a standard indication for surgery. Always beware, if the patient walks into the chamber with a painless deficit, which has been there for more than a couple of months, then these patients are not going to improve whatsoever you do. The deficit is not going to improve. So in this patient, you have to talk to the patient, their attendants, and make it sure that the surgery won't help in neurological recovery. At the most, surgery will be intended to prevent further damage, but not to recover this already lost neurological power. Now, what are the options? The standard option is if the canal is compromised, open the canal. So it can be laminectomy, it can be nerve root decompression, it can be internal decompression, it can be done by open, it can be done by endoscopy, whatever it is, it has to be decompressed. So whether one decompressed by a open laminectomy and medial fascectomy or by endoscopic work, it's immediate. The canal has to be opened. But if it is multiple level, it's better do an open job, because doing at 4 places or 5 places with MI system or endoscopy is very taxing. Now, special situations, degenerative listhesis with LCS. So if the listhesis is just grade 1 and there is no instability on dynamic X-ray, plus we are not intending to remove any disc in this, these patients can be managed with simple as we manage simple lumbar canal stenosis. But if there is accompanying disc which needs removal, there is an instability documented, then the same degenerative listhesis will qualify for decompression with fixation. Now, LCS with disc. So if there is a disc, whether it is a generalized disc, whether it is a hard disc, don't remove it. If it is a focal disc, extruded, protruded, which is matching with the symptoms on that particular side, always do disc excision in such cases. Junctional stenosis. Junctional stenosis is that in which already, like for an example, L4-5 decompression has been done, and the patient develops stenosis at an upper level. Now, this can develop as a part of the disease itself, degenerative process itself, or it can develop because of instability that has been made during previous surgery. Suppose a facet at the upper level has been removed, or it has been damaged, the joint has been damaged, it can lead to stenosis at that junctional area. So in such cases, if there is no documented instability by dynamic X-rays, only decompression will suffice. But if there is a dynamic instability, always add in fixation in such cases. Scoliosis. So if the scoliosis in with LCS is less than, say the curvature is less than 20-30 degrees, and the patient is not having significant back pain, same like its management same as routine LCS. But if the curve is significant, more than 30 degrees, there is a significant back pain, then it will need fixation. So basically, fixation is to be added in lumbar canal stenosis only if there is significant back pain, there is radiological signs of instability, and if while doing surgery you're not prepared, but you remove too much of facet, there is a iatrogenic instability that has been caused, or we expect that iatrogenic instability will happen. Suppose like in example, like we are decompressing a stenotic canal at L1, L2, and there is a big disc. So while removing the L1, L2 disc, a big disc, you need to take out so much of facets that it might lead to pars injury also. So in such cases where we are anticipating iatrogenic instability, add fixation. So post-op instability. So pars might be injured. So in such cases we might have to fix. Even facetal arthropathy, we do facetectomy, partial medial facetectomy. So if more than 50% of the facet has been damaged, it might lead to instability. However, if the disc is not being removed, so it has to be all tailor made. So if the part of the parts is fractured, but the disc is totally intact, we have not removed the disc, the other side joint is totally intact, we might leave it like that, and then going for brace, good physiotherapy, and then check out during subsequent follow-ups with dynamic X-rays. And if later on the patient develops instability, fix. Otherwise, we can just get away even in such cases where a unilateral pass has been fractured, but the opposite side joint as well as the disc has been untouched. So all those things are has to be tailor made in that particular scenario. Some special situations. Now, failed wax surgery that we usually come across is most commonly because of the wrong level. So inadequate decompression can be another cause, or if there is accompanying facet cyst and we didn't remove it, And along with that, even we have to do fixation. So if we don't do it, don't do the fixation, then it might lead to recurrence of that cyst. So my take-home message for lumbar canal stenosis will be always have a good clinical examination, take good history, and look out for the specific cause as to how why the patient has come to you. If there is any acute reason for the patient to be in clinic, you have to localize why that what is the cause which is causing that acute exacerbation of the pain. And if it is a unilateral pain, what is the reason for it? Rule out any clinical instability, rule out that there is no other medical problem, no vascular reasons leading to it. Also check out that there is no accompanying compression in cervical or thoracic issues, or there is no other problem with the knee and hip. So, and once you have done that, it's only lumbar canal stenosis. Non-surgical treatment is only for lifestyle modification and for people who are not significantly disabled. And once the patient is significantly disabled, surgery is the only option. What kind of surgery? It depends on what the pathology is and what's your choice of operation. Thank you.
Thank you, Gautam. That was excellent and really covered most of the areas that are needed.
Yeah, thank you, sir.
Questions from the students?
Yes, so one thing in between, sir, there are a few questions which I have noted down from the DNB previous year. One thing they have asked about the pathophysiology. Sometimes they ask about the pathogenesis. So about these two things, actually, both the same or little bit different?
I mean, I think he covered that area quite extensively in the initial thing.
For lumbar canal stenosis.
Yeah, the same.
Pathogenesis is the actual cause of and how it happens, and pathophys is just another way of wording it. You really need to answer more of this, the same things.
So
that initial diagram which I showed, and all how the facet and this Kikadi-Willis phenomena which is being explained, how the disc degenerates and the facet joints and the canal, the central canal. So all those things has to be mentioned, and that venous and arterial blood flow that I have mentioned. So all those things will constitute of this pathophysiology.
I think that was covered quite adequately.
Yes. So, just one thing related to the lecture. So you have mentioned about venous hypertension. That means that is obstruction of the venous flow or insufficiency. Like those things will be.
So if there is a canal blockade, the venous outflow will decrease, because the space has been occluded. That's what I meant. So because of that, the backflow is already there. So the venous outflow decreases further. And so the arterial inflow decreases. Now one has to remember the root. When we see the vascularity of the root, the part of the root which is within the canal that receives supply from within. So and the part of the root which is outside the neural foramen that receives the blood flow from outside. So there is a junction at the foramen region. So if the inner portion is being ischemic, the symptoms will be there.
So another question they have asked about the difference between venous and neurologic claudication. So that
vascular
and neurogenic.
Arterial.
So vascular, in all those vascular things, we'll get the other signs also, like the limbs will be cold, the skin will be shiny, and main claudication will be in neurogenic claudication. The patient will walk for some distance, then will have to stoop forward, will bend forward, flex, or sit down, and then it will get relieved. So, and over a period of time, the the neurological claudication distance will keep on decreasing as the months and years it goes by. In vascular, it can happen anytime. It need not be after 100 meters only. It can happen anytime, depending on the vascular issues. And this neurogenic claudication, there will be accompanied with that even sensory dermatomal symptoms will be present. And plus that clinical examination, the vascularity that you have to check out.
So you have mentioned about the conservative treatments, like when usually during the post-graduation, we used to, whenever there is a case of pain of the lower back with the radiation, we used to write like that don't bend forward and other things like not take the heavy weight. So for these things, this is totally different that canal stenosis. So for conservative management, what is advice we can give to the patients?
So conservative management, as I told you, only for patients who are not significantly disabled. So the disability is just for a few days or not very bad. Conservative management in the form of NSAIDs, some vitamin supplements, and lifestyle modification. Not to sit for a long time, not to lift heavy weight. I usually don't ask patient not to bend forward. Bending forward is not going to harm anything because the spine is not that unstable. So bending is allowed, but working for a long time while in bent position or lifting heavy weight with the spine in flex position, that is to be avoided.
In fact, if you look at spinal stenosis, a lot of the cases are actually worse if they hyperextend their spine.
Yeah.
And they can actually walk further if they walk with a slight flexion. Okay, so like if they're riding a bicycle, they're able to do it for long distances. And similarly, if they walk with slight flexion, the space in the canal might increase.
So that's why.
Another. So actually, when they walk, they actually brace with the spine a little flexed as one of the conservative treatments, which is not used very often nowadays, but used to be used.
So they crouch forward, and this was the reason why that interspinous ligament came into picture. So it used to distract the thing, but and also used to cause some amount of flexion, decrease the flavum buckling. So it increases the space. But of late, it came and it went. As soon as it came, it went.
They don't last very long.
Yeah.
That's the problem. The benefits didn't last very long.
Yes.
There are these dynamic fixations, etc., which they still try before they fuse it. But I think it's so the two important things are, one is the coexistence problems of instability. Okay, so you need to, every spinal stenosis is not unstable, but the ones that are unstable, you can't just decompress, you also need to stabilize them and fuse them. Okay, similarly, you can have fairly extensive canal stenosis, multiple levels without significant instability, where you might just do a decompression. Okay? So we've had to sometimes do it all the way from L1 to L5 or even more, and just decompress, and you can see the sort of spinal, it's not the cord there, but the neural tissues swell up as you make space for them. Yes. Because they've been constricted for a long time. Okay, so one of the signs of instability is when they are sitting for some time and they get up, that's when the pain increases. Or if they're standing, just bending suddenly, then the pain, or extending suddenly. So those are signs which tell you that there's also some instability. If they just have claudication, it may just be the compression of the nerves that are causing it when they're walking. So those are the things you need to look out to decide. One is whether they need surgery. Second, if they need surgery, what kind of surgery do they need?
So there are a few questions in the
need
chat.
To rule out other causes. I mean, we every now and then see patients who have been operated on the spine and their problem is on the hip and vice versa. So those are things you need to really look. So don't forget to examine your patient carefully.
So there are a few questions in the chat box. One asked by Narayan. You want to know why thoracic canal stenosis is not common?
Yeah, because this stenosis problem is more because of degenerative issues, right? So lumbar spine is mobile. That's the foremost thing. Thoracic spine is not. And thoracic compression, whenever it happens, it will be more of the cord symptoms that you will have. And you get symptoms like flavum hypertrophy, as well as flavum ossification, as well as thoracic disc. You get those. It's not that common, but it does happen.
Another question, sir, by Dr. Avinash is that stoop posture is same as crotch posture that he want to know.
I think so. It's same.
So crouch is different when you're talking about CP or something, when you're flexing your knees, etc. as well. Okay. So when you're talking about crouch gait, that's a different thing. When you're talking about stooping or flexing forwards, that's different. Okay. So I don't know what he's asking specifically, whether that's was his doubt or something else.
Yeah, Avinash? Yes, sir.
So I studied about a stoop test for the LCS. So,
Yeah, so you bend forwards, your pain decreases.
No, sir. It said you ask to patient to walk briskly, and when he walks for some time, then he assume a stoop posture.
Exactly. So that's because
I wanted to know what is a stoop posture.
Stooping is bending, na? Bending your spine. So you're flexing forwards. So your canal space increases. Yes.
Yes.
So
that's a test which you can do in the OPD, where you keep making him walk up and down, and then you'll tend to bend to accommodate the swelling in the cord or in the neural tissue.
Yes.
So I think
compression on the neural tissue. Okay.
The next question also got answered. Like, what is the basis of a stoop test you have asked? So I think.
Yes, sir. I wanted to know that. Yes.
And crouch is different altogether. Crouch is your knee is also in a CP child. You walk with a flexed knee and hip, and because your motor power, it usually means your quadriceps are weak and your hamstrings are firing too much, etc. So it's a different thing, more complex. Yes. And there are various causes, so you need to really assess them much more carefully. Okay, I think thanks very much, Gautam. I think we'll call it a day now.
Thank you, sir.
Till next week. Okay, bye, everybody.
Thank you, sir.
Bye, sir. Thank you. Okay, Janki.
Thank you, sir. Thank you so much.
Thank you. Thank you.